In a lot of our network development projects, we've got a lot of grantees working on integrating behavioral health with primary care. And during the All Programs meeting in Washington, D.C. early in 2018 and through the course of several one-on-one coaching conversations with grantees, we've heard a lot from you about challenges associated with workforce and workflows in the course of your work to integrate behavioral health into primary care. So we're fortunate enough to have Dr. Carrie Cadwell with us today, who will share some strategies for addressing some commonly reported workforce and workflow-related challenges that we've heard from a lot of you. Dr. Cadwell currently serves as the CEO of 4 County Counseling Center, which is a community mental health center in Indiana that serves approximately 8,000 consumers annually. Dr. Cadwell earned her doctorate degree in clinical psychology from the Adler School of Professional Psychology with a certificate in cognitive behavioral therapy and a specialty track in neuropsychological assessment. She's worked as a clinician in both outpatient and residential settings and has an outpatient clinic managerial background. Dr. Cadwell has developed programs and practice within integrated healthcare, including primary care, emergency room, hemophilia thrombosis centers, federally qualified health centers, and reverse integration for behavioral health. She's participated on state-level committees for the Indiana Primary Care Behavioral Health Integration Initiative. So we're really happy to welcome Dr. Cadwell here with us today. And Dr. Cadwell, I will turn it over to you.
Great. Thank you, Shannon. I appreciate it. We have 3 objectives that we're trying to achieve today. So I would like to go ahead and talk a little bit about those as they relate to workforce and workflow issues, is to give you some idea about what goes into building a behavioral health, or an integrated, I should say, workforce. What are things to consider when you're thinking about workflow? What are strategies and things to keep in mind that address data sharing and some best practices to move towards in that arena? And really, we're going to run the gamut anywhere from how am I addressing workforce and workflow issues. I've placed a behavioral health clinician inside a primary care practice, and now I need to really work at building momentum on that project. So single site integrated projects, to thinking largely about what does workforce and workflow mean when you're thinking about integrated care delivery systems. So 2 things that I want to just kind of highlight out the gate is that when we're talking about integrated care, I often think about the book Who Moved My Cheese, which is a phenomenal book about how we need to adapt. And this is really what we're doing in healthcare at this point in time, is looking at how we bring, which you'll hear affectionately many people in the field refer to, the head and the body together through the neck, and really think about whole person care, which requires all of us. It requires providers and agencies on the behavioral health end and providers and agencies on the general medical end to really think outside of their lane, to shift gears and think about how health should look forward. So I say that because sometimes what we can do is we can think about how we do care today and how we take this new idea of integrated care or behavioral health care and we bring that into an already existing system of care. And really integrated care, what I would suggest for all folks right out the gate is to think about how does workforce and workflow have to change for everybody for us to achieve the potential that integrated care presents when you have teams working together at all ends of the healthcare sector. And so we'll talk further about that as we get along or go along in the presentation. It also means for us to think about, even when you're on the right side of the road, you'll get run over if you're just standing there, which means that, we can say we're doing integration, but if it is that we're not constantly adapting and evolving what integration looks like within our systems, that, we can be on the right side of the road, but ultimately not be hitting the outcomes and targets that we want to. So there's this piece of getting kind of on the bandwagon with integration. And then there's this component of continuously assessing, reevaluating, and evolving your integrated model to meet your community needs, your medical neighborhood needs. And when we think about workforce, I really want everybody to think about workforce in a very, very broad way, which is how do you medically enhance behavioral health and how do you behaviorally enhance medical providers? That is a a term or a phrase that I have heard Alexander Blount, who is a nationally known figure in integrated care, reference in his presentations many times. And I think it's a good way, a good foundation to start with when you're thinking about workforce, which is that it's not always about the distinct specialized providers. It can sometimes be about, at every layer of the care that we provide, how do we understand and provide the training, support, guidance at all levels. So medical assistants, nurses, physicians, care managers. Again, how do you medically enhance behavioral health providers and behaviorally enhance medical providers? When you're talking about whole person care, everybody has a responsibility to get a little bit of knowledge. They don't always have to be a specialist. The other thing I want to mention out the gate is that one model of integration equals one model of integration. So there's two things I think about when it comes to building integration, and that is, one, you can look at, and it's readily available, all you have to do is Google levels of integration, and what you'll see is that there are multiple levels that could range anywhere from a referral relationship, a co-located model, to a collaborative model, all the way to what we might reference as a fully integrated team-based model. And so really all of us strive for achieving that highest level of integration, but we also have to be practical. We have to think about where can we start. And that is really an important variable here when we're talking about rural practice. Much of my experience has been in rural practice. And what I know with working with all of my partners in rural communities is that we oftentimes struggle with resources. We oftentimes struggle with where are we going to get our workforce. And we find ourselves within our rural communities competing for a limited workforce resource. And so we have to think about where can we start. And so that doesn't always have to be the highest end of the spectrum. It needs to be wherever you can start. You'll hear me say just start. So we just need to get out the gate, and we need to have a sense of what do we want to achieve here. And so one of the things that you'll come across, right, if you're in behavioral health or your medical practice, we value research. And so we'll look and we'll say, okay, these are the models that really create the best possible outcomes, right? And we want to adhere as much as we can to practice models that achieve the health outcomes because we're all certainly under the gun to, manage our costs of care and think about, how do we move towards value-based reimbursements. But at the same time, again, in a rural community, you have to think about where can I start, what can I build, what are my resources, and then the other component of this is that, if I can't do the thing that has shown the best possible health outcomes, again, the question becomes, where do I start? And what does my community need, really? So where you start depends on a lot of different factors. And so I would encourage, if you don't have the resources to kind of adopt a full integrated model, that shouldn't be the thing that serves as a barrier to you starting where you can in order to build health within your community and the populations that you serve. The other background piece to this that I want to kind of mention is that, and these are the principles that you see in front of you, we're really here are principles of care that are driven off of the patient-centered medical home model. And really these are strong principles to apply in behavioral integration also. Whether you, again, are adopting a full patient So another component of that is measurement-based treatment to target. And so when you are a direct provider of care in an integrated setting, we need to set targeted goals, and we need to be constantly assessing whether we're meeting that goal, whether we're getting the outcomes under the defined period of time that we're looking to achieve. And then when we are not, that we're adapting, that we're thinking about what needs to change in our treatment plan. A piece that I want to highlight about treatment plans is that we also need to have a shared care plan. We need to know what each part of the team plays, what we're all trying to achieve, and to be on the same page about that. Another component to this is practice-based evidence. And again, it goes right hand in hand with treat to target. So you have to have tools that you are regularly screening with, that you're regularly reassessing the client to see if, in fact, they're moving towards the outcomes that you want to achieve. And that in the course of providing treatment, that we're really using evidence-based care and evidence-based treatment protocols. I think we're all pretty familiar in healthcare with the concept of accountable care. So really, this goes straight back to the bullets we've just talked about. Do we have a goal in mind? Do we share that goal amongst the treatment team? How are we moving towards it? Are we choosing methods that are evidence-based? How are we assessing success and then adapting when we need to be? Because eventually we may find ourselves in healthcare really fully embraced within the value-based model, and then so those pieces become that much more important under that type of reimbursement model. And at the bare minimum, I shouldn't even say bare minimum, really what drives all of this and achieving the outcomes in integrated care that we want to achieve is care coordination and communication. So when we're talking about workflows, or if we're simply talking about how we leverage workforce, we have to always be thinking about how are we coordinating care, how are we communicating amongst the team, how are we assuring that we're reasonably all on the same page, moving together and sharing relevant information. So I mentioned that we would pretty much run anywhere from what are we doing when we have a single site integration project, or really you're embedding a behavioral health clinician within one location, to large picture pieces of integrated care delivery systems and how large groups really think about their role together in integration. So to go to that smaller end of the scale, one of the things that comes up a lot is, okay, I've got a behavioral health clinician in an office, so we're out the gate. We just got started. However, I'm not getting that many referrals. The provider isn't sure really yet how to interface with me. We're not sure how to make the connection together. I'm getting a lot of traditional referrals for behavioral health. I'm finding myself doing 45-minute sessions with patients inside of a primary care office, and nobody else in the office seems to quite know how to use me yet. And so what I'm just going to review here is just little things that in my own practice when I first got into this that I thought about doing, did do, and found it to be a way to build momentum. Momentum for the practice of integrated care, but also these are ways to think about how you have to, when you do integration, you have to have a champion of integration. You have to have somebody who gets in there and is chronically cheerleading, demonstrating how we can do things, building momentum amongst from the top down and the bottom up so that everybody can embrace integration. And so even in a small practice site like that, it may be that somebody finds that, they have to really kind of go in doing the thing that is a very quick sell to most in primary care, which is that somebody can help me with the mental health and substance use needs of my patients and my patient population. And remember, these are the doctor's patients, so they have to see value in what it is that a behavioral health clinician is bringing to the table. If you just have to find a place to start, if you start there, again, it's okay, because the idea is that you can take incremental steps towards moving towards addressing other types of health issues, which could be that second step, which is then expanding to health behavior change. So let's say you get into an office, you are addressing the needs that many primary care doctors are saying they're having difficulty accessing when they send referrals, again, traditional mental health and substance use issues. And then you're working with them, and then they see that actually you can do and they can trust their patients to your care. Well, then it's the next easy sell to say, guess what? You know, there are other things I can do for you. I can work with your patients with diabetes. We can work on health behavior change. We can work on addressing tobacco. We can address cardiovascular issues, again, from, you know, a lifestyle and behavioral health management end. And so, again, you're building trust. The provider's office has built trust in you, and then you can extend your reach. This isn't, I'm not saying the way that anybody has to do these things, but when you have a system that is not as well-versed, comfortable, or doesn't understand integration as well, you know, a stepwise model can work out very nice in building momentum. Another thing you can do is when you're talking about both building connection with that medical office, but then also beginning to create behaviorally enhanced medical providers, is to introduce something like the tip of the week. So digestible, short digestible bits of information that are sent to various providers within the healthcare system that allow them in a few sentences or less to take a bit of behavioral health information in, to have a quick, hey, this is something I could do with a patient that comes in front of me when I know that this might be an issue. And so again, you can find success in saying, both building trust because you're providing some sense of, hey, this is an evidence-based strategy that you can use with your patients, and I'm not the one that has to provide it, meaning the behavioral health clinician. So you're building trust, you're expanding your reach within that healthcare entity, and I wouldn't suggest that people just go out and do these things. I'd really suggest that there be a lot of internal discussion about what would be most useful to the specific health system. But it's a great way to get communication out there. Another component is, again, not just thinking about your role as a direct care provider, but how do you help staff within the offices that you're serving handle change? So if you're working with a group that has decided to integrate at a time when they're also pursuing patient-centered medical home certification, right? Handling change is well within the sphere of behavioral health clinicians. How does that directly relate back to integrated care? Because you have to build trust. Just because you're in an office doesn't mean that anybody on the team is naturally just going to consult with you at all times. You have to demonstrate to that team that you have value, that you can produce outcomes, you know, that you can give them digestible bits of information. And another great way to build trust is to have brief educational trainings or educations at a lunch hour. And I've done things like that, and again, it creates a very quick momentum. You'll find staff come up to you afterwards and they're asking you questions about, you know, anything that you presented, or it makes them think of a patient and they're thinking, I didn't even think about that patient as somebody who could benefit from your services. So probably in a lot of ways, this is a lot like having a very clear marketing strategy within the healthcare system. And so if that's an easier way to think about it, then we should just say that as a clinician in an embedded integration setting, or as a group who's trying to build integration within a healthcare system, there has to be a champion or an internal marketing strategy that builds momentum for that. Another easy way to build momentum, or at least to assist the physicians, and certainly integration often results in a lot of physician satisfaction because they feel like they have support, but is to provide them tools that help that make their life easier. So tools that suggest, hey, if this presentation comes in front of you, this may be the treatment recommendation that you might make. So anything that helps them guide some clinical decisions. And then additionally, which we kind of mentioned in the previous slide, is that you have to have the screening tools in place. And we'll talk a little bit about this as we go along. And then thinking about how do you make the connection so with the staff. So if you've built trust and they're trying to think about who should you see, right, if you are going to have direct patient contact, then helping to teach the medical assistant, for example, or somebody else in the office to, you know, scrub medical records, or to look at, hey, does this patient present with A, B, or C, and would they benefit from a particular integrated service? or you personally as a behavioral health clinician scrubbing the schedule and looking at who could I begin to see and make connections with, and help to really get the process started of making the connection to the patients that you know would benefit most from your service. Some larger considerations I would just suggest, some of them I kind of already talked about, is one, asking yourself the question, if you're a healthcare office or you're a healthcare system and you want to adopt integration, are you taking a traditional behavioral health clinician and putting them in an integrated setting? So why that question is important is because what we're not trying to achieve here is traditional integrated care. Again, start wherever it is that you need to start. If you want to co-locate traditional behavioral health services in a primary care office, then there's nothing wrong with starting there. The liabilities or just the barriers that will come up quickly is that similar to when you refer a patient out for care, the access will become quickly backed up. And so thinking about how we develop brief, solution-focused intervention schedules that better align with a primary care office schedule, you're just more likely to maximize that person well. I've also heard individuals when they've tried to quickly say or describe what integrated care is, it's like an EAP. And certainly I understand where that idea comes from because, again, brief, solution-focused services, but it goes beyond an EAP. We're looking at brief, solution-focused interventions, but ones, again, that don't always involve direct client contact, that run anywhere from direct services to larger population health. And so what we do is we run the risk when we refer to it, in my mind, as it's kind of like an EAP, of really going back up to that first bullet, which is, are we basically going to be putting some just short-term, solution-focused, traditional behavioral health within the primary care setting? And I'm suggesting you can definitely go further from that, and in going further from that, you're likely to get more maximum outcomes, really, if you will, when you're thinking about the entire sphere from direct care to population health. Other things that you need to think about are training needs, team training needs, including, building a supervisor workforce. So part of it is that, when we put integration together, oftentimes when I've been with teams, they kind of look at each other like, who's going to guide the process here? And behavioral health clinicians who want to go into integration have learned a bit, maybe gone through some training for integration, find themselves in an office, but are looking for some supervision. Who do I turn to? Who's the specialist or the senior clinician that will help give me some feedback in these areas? So these are things that I would think about out the gate, right? What are our training needs? What are we trying to achieve? And then two, if we do require some level of supervision, who provides that? Of course, when you're talking about building those models with students, then you definitely have to think about what the supervisor role is and ensuring that you're supporting the development of supervisors as much as it is that you're developing the trainees, doctoral interns, residents, whatever type of student you have that's working within that integrated health setting. You'll want to consider what your metrics are. Part of this whole concept is that you're trying to achieve targets. So thinking about from the very beginning, what are the key metrics that will help us decide if we're meeting our goals, not just on an individual patient basis, but in our integrated care model, deciding on those metrics early and setting up your system to be able to monitor that from the very beginning is important. And of course, largely, all of this then comes back to workflows and having a strategic plan or map for how you're going to do what it is you're going to do. One resource that I would point you towards is the GROW Pathway Worksheet. So GROW stands for Goals, Resource Assessment, Options, and Workflow. And really you follow through a series of questions that lets you think about, number one, before I ever develop a workflow, which comes at the end of that, I got to know what my goals are. What am I trying to achieve? What are my goals for integration? Secondly, what are the resources that I have to achieve those, right? So if I have these goals but I don't have the resources, then maybe I got to do some realignment here. And in rural areas, again, that resource assessment is a really large driving force and where you can start often. And then once you know, here's my resources, here are my goals, there might be a question then of options, right? What are all the different ways that we could potentially achieve this? And then once you've decided on which pathway you're going to take first, then it doesn't become so difficult to decide what are the workflows we have to set up. But within that workflow piece, I highly encourage people to think about, again, how you don't just take an individual and put them into traditional workflows, but how workflows even that exist within offices, within healthcare systems, may need to be reassessed so that the entire care team can work together. So another component when you're talking about integrated care, that I really want to put on the radar for everybody, is there are probably 3 areas that, from my vantage point as somebody who is involved in the public mental health system, that we think a lot about all the time. And I think these 3 things are things that even when you're doing integrated care, behavioral health coming into medical offices, or for that matter, medical providers being embedded in mental health offices, or what we call reverse integration. And that is not just the role of mental health issues, but that's the role that you have to lay out, think about, consider in addressing substance use issues, and then trauma. So in the public mental health sector, it's well known that the vast majority of the patients who come into the public mental health sector have been impacted by trauma. So you may have mental health and or a substance use concern presenting at the forefront. It's the symptom scene at the surface. But it's not unusual in our business to know that right underneath that surface is trauma. And so many of you might have been hearing a lot about this concept of developing trauma-sensitive practices, which is thinking about trauma all the time because it's difficult to talk about. There has to be a lot of trust there to have that discussion. And so you might not know as a provider of healthcare and or of mental health that that's really in part a driving force or a concern that may need to be addressed or there's healing needed there. So I think it's equally as important that when we're talking about integrated care for us to keep all 3 of those things at the forefront and also to understand how trauma, or what we'll call, it is oftentimes referenced as adverse childhood events, can drive outcomes in healthcare, and why it becomes important to consider trauma and trauma-sensitive practices within the scope of integrated care setup and workflows. So ACEs, adverse childhood events, you can Google it and get a long history about how the concept of the adverse childhood events has developed into an entire movement nationally, back to when the first physician conjectured or hypothesized about how different types of traumatic or just adverse events have impacts on mental health, substance use, and health outcomes. And I'll let you research that story for yourself and would encourage you to, but want to give you some context to what an ACE is. So an adverse childhood event is, at this point, it's kind of a defined list because it's been researched a number of times, a defined list of events that may have occurred in early life of a child. Some of those being directly potentially traumatic events such as neglect, physical abuse, sexual abuse. Others of them having what could be adverse impacts on a child, such as having family members who have gone to jail, having a family member with a substance use issue. So it's a defined list. And so what we found in the research, of what has been found in research studies, is that depending on the number of those ACEs endorsed as experienced in early life by adults, that it drastically impacts the odds of somebody developing poor health outcomes and even early mortality in many cases. And that oftentimes what we look at is that, first off, that, ACEs are pretty common, that they tend to cluster together. So if you find one, that it's not too unusual to find some additional ones, and that they have a dose-response relationship to many health problems. So you can look at it in 3 buckets: no ACEs, 1 to 3 ACEs, 4+ ACEs. And why I bring this up is that when we talk about population health, the concept of considering how ACEs impact care, how this could be used in patient registries to develop workflows about who needs to be monitored or who may benefit from a certain layer of care. is a good idea. Now, not a simple idea, because certainly there's a lot of discussion that should occur around, whether we should be asking these questions of patients. How likely are they? What kind of relationship do you have to have with a patient to ask about their history of trauma? And in the same vein, we should be asking these questions, because if I think about the experience that I personally have had in integrated care and that I've talked with many of my colleagues about in integrated care, is that if you go into a physical health record, if you review what patients are talking to their doctors about, when they have good relationships with their primary care doctor, it's that person that tends to know the most about that patient. And so the amount of information regarding the mental and emotional functioning, substance use, and even history of trauma that a primary care physician may know about their patient who they've been following for a very long period of time, or a pediatric patient that by default they know because they've been following the developmental course of the family and the individual for very long, already exists. So thinking about how you take these kinds of questions, risk stratify them to develop workflows, is again another way to think about how we approach population health and integrated care. And to give you a sense of, so how do these odds ratios play out, this is an example of one study that was done. And what you'll see if you bucket these into no ACEs, 1 to 3 ACEs, 4 to 8 ACEs, that the odds ratios of outcomes like of heart disease, smoking, drinking alcohol and it becoming a substantial problem for an individual, suicide attempts, IV drug use, those odds ratios jump substantially. And so you see kind of in a quick fashion how impactful trauma can be on health overall. You'll note that in the list, and there are more health outcomes that are looked at besides heart disease, but you'll see that it impacts physical health, mental health, and that it's not selective, right? So again, understanding the role of trauma and keeping that in mind as you're developing your models are important. And there are a lot of resources out there for how in primary care one can consider trauma-sensitive practices too. So not just even in the assessment is what we're talking about, screening, risk stratifying, but there's a lot of literature that can just help guide a practice and thinking about what are some of the practices that they could implement that would move them towards being more trauma-sensitive. The other piece that, when we think about trauma, and we think about what people have been exposed to in daily life, it brings up a third component of what we should consider in integrated care, which is social determinants of health. So this is just a quick slide that, notes, again, what tends to drive health outcomes. And, what you'll see is that there's a big portion of this that has to do with individual behavior and then social and environmental factors. Knowing how impactful social environmental factors are, first off on individual behavior, and then on health in general, people often will say, well, okay, so how do we even address that? Like, what are considered social determinants of health? And so what you'll see in front of you is just a quick bucketed figure of some of the things that need to be considered from that social determinants of health perspective, whether it's the economic status of the individual, what the neighborhood and physical environment is, education, food, the community and social context and resources, the healthcare delivery system that exists, and all of these things, again, some of being applicable whether it's an urban or rural area, but we all know in our rural areas that, many of these things, because of resource limitations that can exist, can become that much more of a profound factor in terms of how do we address this under a limited resource situation. Now, why I kind of lead into this idea of, okay, we think about how we address things within an integrated site, like a site-specific model, to beginning to think about population health and social determinants of health is because really, in a lot of ways, there is a model that already exists that helps guide us think about how you set up workflows and to address very specific parts of integration, from here I need to provide direct service, to how do I address at-risk individuals, to how we address prevention, including social determinants of health. And so for those of you who are familiar with response to intervention in the educational arena or positive behavior intervention support systems, that model promotes within the educational system that we think about how we have universal interventions for the vast majority of individuals, right, which is really the prevention piece of this, the prevention piece of for achieving good educational outcomes. And then you have students who might need a little bit of extra intervention, right? It could be instructional intervention, or it could be that they're showing some at-risk behaviors within a school setting. And so you develop interventions around a secondary tier to address those, the sum of those who experience at-risk concerns. And at the very top of the tier, which should be the smallest percentage, these are the folks who, you know, they require the most assistance, right? That direct contact with them is essential. This type of model is so well suited for the healthcare sector also, in part because of the workforce challenges that we have. So when we refer in, if we're thinking about behavioral health, to traditional behavioral health, and everybody gets referred into that same layer of care, then by default, this triangle flips, right? We're taking the most limited amount of resources and asking for all of the individuals to be served at that, with that small resource. However, if we flip the script and we think about what do we do at the preventative end? How do we address social determinants of health? How do we develop monitoring systems for populations of patients? And then we think about, hey, how do we all, and what role can we play in becoming behaviorally enhanced medical providers, or vice versa, to begin to impact health for those who have at-risk concerns and do brief interventions. And then we ultimately know and say, listen, these particular individuals, because of the fact that they've kind of moved up the step ladder, they really need individualized attention. Then you really, I feel like, are able to more maximize the workforce you have, both in terms of an integrated setting and in terms of managing the difference between who gets seen in an integrated setting and who might need to go on for some more traditional care based upon a referral setting. We're each going to play a role, right? Even in an integrated setting, there may be those patients who we say they would be best suited to be treated by a traditional behavioral health setting. No different than in a primary care setting when a doctor says, hey, I think this person needs to go on to a cardiologist. I think this person needs to be seen by this specialist. Part of the challenge in front of us is really developing those parameters for our healthcare delivery system, and then setting those parameters within the integrated care setting so that you know, what are my responsibilities here? Who am I targeting? And then who really do I need and have to have a workflow to get them more successfully entered into this specialist care, which may or may not always exist within the healthcare system. A referral may need to be made out. This is an example of an image that I found that kind of lays out how this interfaces with integration as it relates to population health. So what you'll see is characteristics of patients on one side, which let you know, hey, who are the folks? How do we divine those populations as you're moving up that those tiers or that triangle? And then kind of coupling that with, so what would be priorities, right? What are we trying to achieve? What are our goals, and what can we set up? And so to make that more tangible, I'm going to give you an example of a rough draft of a tiered approach that I worked with a hemophilia and thrombosis center when they were wanting to kind of enter in, just get started with behavioral health services inside of their office, but for a large patient population. And they wanted to really say, what can we get out the gate with adults, right? And so what you'll see here is that idea at the far side of the page of universal, the some at risk, and then the few or more complex comorbid chronic needs. And then it pairs that with this idea that, you know, what are their needs, right? So at the very top end of the triangle, those with more complex comorbid conditions, they have high needs. They need more intensive services. Those at the some and at-risk level have a medium need, and so you can develop services around that medium need. And then you have your universal, right? So there's low needs, but you want to attend and prevent as many people kind of marching up the tiers, if you will. And then in between, what you'll see is, okay, so at a universal level, what are some of the ideas, if you're just brainstorming, that, you know, a provider office can consider? Well, you can consider screening, right? You can consider thinking about when somebody screens at a level that moves them to some and at risk. But screening at a basic level would be important. And that wouldn't just be for symptoms. It should be for things like quality of life. You know, one of the things that I often hear people talk about is we want to take something like the PHQ and reduce those depressive symptoms down to 0, right, or down to some reasonable remission rate and sustain it there. That is good, right? Nothing wrong. There's nothing wrong with that, being able to treat to target. But at the same time, what you want to know is, if you're talking about health outcomes, is that there was also something that came out the other side that promoted quality of life. And so it is possible to reduce depressive symptoms or anxiety symptoms or whatever symptoms we're talking about to a level of remission. But a patient still say that they don't have quality of life, right? Because we haven't addressed social determinants of health. The individual is socially isolated. And so hearing that even with screenings of quality of life, it seems often like that can be beneficial. Setting up other types of screeners, such as SBIRT or substance use. Thinking about how you behaviorally enhance the medical team to understand and use motivational interviewing, or having understanding of some brief targeted cognitive behavioral interventions for providers. There's a lot of data out there, even in terms of how important it can be to train nurses in brief cognitive behavioral interventions and the impact that can have even on patient outcomes. Another component of that can be thinking about how it is that you're approaching at a universal level, monitoring patients based upon the data that you're able to look at, abstract, and analyze within your electronic medical record, which can also mean setting up what the Institute of Medicine refers to as psychosocial vital signs. So there was some reports that were put out a couple of years ago by the Institute of Medicine talking about, you know, well, we take vital signs, right, in healthcare all the time, and so maybe part of what we need to incorporate here is psychosocial vital signs. And what would those be, and what would be the most key areas if we were to embed that within an electronic medical record that would help us to track our patients, to risk stratify our patients, and then to respond to them in a tiered way. And so you can get those reports online, and it's a really great starting point for getting your ideas flowing on how you just make behavioral health and psychosocial functioning a regular part of the health assessment, and that you can make decisions about what's needed next based upon psychosocial vital signs. It may even just be questions about stress, or about food insecurity, or about housing. And knowing that if you have patients in the absence of having screened depression that are endorsing a wide variety of social determinants of health challenges, that connecting them with resources is going to be so vital for both their general medical and then their behavioral health outcomes. Moving up into the some and at risk, you'll see then where you can develop other different kinds of protocols. So in this example, we talked about a depression care program. Now, this might not be, again, direct care based upon the embedded behavioral health care manager. Instead, this was an entire program that was far more connected to how the care coordinators in the office monitored impact, had telephonic contact, and coordinated care for those individuals within the office setting identified as having depression on their problem list. So again, it's not necessarily just a licensed behavioral health clinician that can create impacts at any level within an office. And then, of course, then the third layer up from this is really how you use, not only your integrated clinician, but then make that connection to if there's very intense levels of service, what is the care coordination that might have to happen with other entities and agencies to achieve the outcomes that we need. So then we're talking about sharing information also, and so I wanted to point everyone to a report that was written a number of years ago, Managing Populations and Maximizing Technology, and it really talks about the top 10 IT pieces for successful population health management, and I regularly refer back to this. I think there are a lot of good ideas here that really, not having to do all of them all at once either, right? Again, it's thinking about your resources. So that can range anywhere from really how you're leveraging your electronic health records. So you can think about something as simple as, again, how do we involve or integrate psychosocial vital signs? How are we evolving patient registries? I mean, everybody talks to at this point in time about health information exchanges. How do we risk stratify our patients? I really think this is just such an interesting concept that we could probably do so much more with, which is because we have electronic medical records. It's how do we, first off, obviously not let people fall through the cracks, but then number two, how do we see people in terms of their risk level, right? How do we see them in terms of the lens of, which pathway or which workflow we put them on for care? And so I think the more that we engage thinking about populations in risk stratification, again, we just have so much more ability to impact health outcomes for populations as opposed to requiring and totally relying on individual behavioral health clinicians within an integrated setting to do all of that work. And then, of course, things like automated outreach, referral tracking, patient portals, all of these things are going to be so familiar to each one of you listening today. Telehealth and telemedicine, this is an area where absolutely within integration, we should be pushing the envelope and thinking about how we connect the dots. Now, that could be anywhere from the concept of if you are taking in a behavioral health clinician into a medical office, could that be through telehealth? When we're talking about rural areas, we have to consider that we may or may not have all of the providers we need. And so in that case, we have to think, how do we get access? And telehealth is just such an asset for rural areas in that way. Now, it doesn't have to just be, though, the behavioral health clinician. Right now, I'll use the example of we're working on a project under which a school will have integrated health within the school setting. And so that's achieved by behavioral health, essentially telehealthing in to provide services, but it also involves primary care services, a limited kind of menu of those being provided via telehealth into that school setting. So wonderful, because again, when we talk about integration, many times we talk about how do we integrate within a healthcare system, but integration is so broad that you can think about it even in terms of how do we bring integration to where populations exist, where kids are, where families are, where our patients are. And so the more we're able to do that and leverage telehealth, the more successful we'll be. Remote patient monitoring, and then certainly thinking about advanced population analytics. Obviously, there's a lot being discussed and looked at in the area of artificial intelligence and machine learning and algorithms to figure out how essentially you should, what if we can define what treatment approach is going to work best for a particular patient in order to improve outcomes. One other piece that I kind of want to mention here is that so in taking all of this, right, so if we think about what we've talked about and start to bring some of this together, is that to address workforce and workflow issues, you have to know what your goals are. You have to know what your resources are. You have to know what your options are in the face of those. You then move towards your workflow. And if you think about all that within the context of a tiered system, right, that pyramid that we looked at, then you can think about how do we address integration from anywhere from social determinants of health all the way up to how we address directly with in-person care and contact behavioral health, substance use, and trauma needs. How we consider all of that in the context of trauma and adverse childhood events. And then there's this other component, which is, how do we think achieving health outcomes and integration is really about community health, really. It's really, it takes the involvement of the community and thinking about not just the medical neighborhood, but the health neighborhood. And health neighborhood means community. And so I lay this model you have in front of you, I'm really pointing to the 5 arrows that are kind of going around the triangle in the middle. And this happens to be a visual that I developed for the company that I work with currently. But it is a good reminder to me when I started thinking about integration. I would always go back to thinking about, okay, what are the goals of healthcare? And then, of course, right from that, you think about the AAA. And then there came this next step, right? And that is that at a certain point, the American Medical Association said, well, the triple aim is good, but we want to add something in there, and we want to say quad aim, because the quad aim is really about including not only, the consumer experience, lowering cost of care, and having better outcomes, but it really involves thinking about the provider. And it thinks about how we engage providers, because we know that we have better outcomes when our providers feel engaged, they're not burnt out, and they can do what they need to do in order to give good patient care. And so there's the quad aim. And for those of you who are maybe not familiar with the AMA's Step Forward curriculum, I would really encourage you to seek out some information on that front. It is a really great resource of modules that incorporate all of these pieces, but also including the importance of addressing provider burnout and the role of provider input into how we achieve our intended aims in healthcare. But I'm going to add something here, really, and that is this idea that, not only are we having to think to get better outcomes about the consumer experience, and that's right up the alley of integration, because getting really one-stop shopping, right? Being able to provide a patient whole person care where they find themselves, really thinking about care coordination and better outcomes, that we need to be able, particularly when you layer in behavioral health, that you have to be able to show that you're achieving the aims that you intended to, right? That we develop accountable care. And that we're also thinking about the cost of care and the process of this. And that's a big driver of movement towards integrated care, as we all know, and the research is pretty clear on the impact that the presence of behavioral health issues have on cost of care when coupled with other chronic health conditions. We want to become a provider-driven organization. But when you're talking about achieving outcomes at a level under which you're preventing, or you're thinking about social determinants of health, there's another component here, and that is community engagement. And so I suggest that you think about the healthcare aims when you're trying to achieve integration as really the quad plus aim, right? And that engaged community on this front, buy-in from the community on achieving the goals and being collaborators and connecting and being viable resources as a part of that health neighborhood is equally as important, particularly when addressing the social determinants of health. So if nothing else, if we come just down to some core concepts here, I would ask you to think about where are you in the medical neighborhood, but better yet, the health neighborhood, right? So don't think of the healthcare system and how we integrate just there, that we think about how you become engaged partners with the community for that health outcomes, particularly with social determinants of health, and that you begin to think about workforce and workflow as it relates to integrated delivery systems, not always just single-site integrated care. So we're always going to have these single-site projects, embedding people within locations, and that is an essential part of integrated care. But the big picture is integrated delivery systems, right? From your health plan partners to your healthcare systems to your community resources and community partners. And bringing all those three things together really is so valuable, so important when thinking about building integrated care and how we all play a role in a bit of the workforce problem and also a bit of the workflow development. So I appreciate everyone listening today. I've enjoyed talking about integrated care. And so I hope you have a wonderful day, and we will talk soon. Thanks.
Thank you, Carrie. This really felt like a lot of valuable information. You have a really extensive set of perspectives and provided some really good tips for folks who are working on behavioral health integration and some of the challenges that they're facing. I think it's particularly helpful for them to hear from someone who has walked in their shoes and has gone through some of what they're experiencing, so thank you very much. For those of you listening to this recording, if you have questions or would like help getting connected to more resources or some personalized technical assistance, as always, feel free to contact us at the network development team here at RHI. So thanks everybody for joining us and have a great day.